Human immunodeficiency virus and the lung. Etiology and epidemiology. Lung pathology is common in patients with HIV infection and particularly in those with low CD4 plus T cell counts. Like the immunocompetent, they are prone to the common viral and bacterial infections, but they are also at risk of atypical infections such as pneumocystis carinii pneumonia, PCP. PCP was a common cause of death in AIDS patients until the introduction of septrin prophylaxis in those with CD4 T cell counts below 200*10^6/L. It now tends to be seen as a first presentation of the disease in previously undiagnosed HIV. Tuberculosis, TB, is a major cause of mortality and morbidity in HIV patients, particularly in developing countries, and non-tuberculous mycobacteria including Mycobacterium avium intracellulare, CD4 T cell count less than 100*10^6/L, M. kansazii and M. kelloni are also seen. Multi-drug resistant TB started to become a substantial problem in the early 1990s, with a mortality between 80 and 100%. The relative numbers of patients infected with multi-drug resistant TB in Western countries remains small, but the plight of the developing world is uncertain. Cytomegalovirus, CMV, pulmonary infection rarely occurs alone. If it is found, its presence does not affect the outcome of other lung infections. Fungal infections, e.g. Cryptococcus neoformans, tend to be seen as part of a disseminated syndrome. Tumors such as Kaposi sarcoma, KS, commonly occur in the lung as well as the skin, although lymphoma tends to arise in extrapulmonary sites in HIV patients. Clinical presentation. The management of HIV patients with pulmonary symptoms can be difficult. Do not forget that acute shortness of breath can be caused by bacterial pneumonia, asthma, or pulmonary emboli, just as in the immunocompetent. However, patients with HIV more commonly present with a history of gradually increasing breathlessness, fever, mild to moderate sputum production or just a dry cough, and occasionally with hemoptysis. Physical signs. How unwell is the patient? Is he or she hypoxic? Look for clubbing. Look closely in the mouth and on the skin for KS as well as other stigmata or evidence of immunodeficiency. Note any intercostal recession. Listen for crackles and wheezing. Investigations. Chest radiograph. This may be virtually diagnostic, Fig 28, on the other hand, it may appear normal, especially in early cases of PCP and KS. NB. Do not allow a false sense of security if the CXR appears normal. Oxygen saturation. Check both before and after exercise. Low post-exercise oxygen saturation is typical of PCP. Arterial blood gases. Hypoxia demands explanation even if the CXR seems normal. Bronchoscopy. Because of the wide range of respiratory pathology seen in the immunosuppressed, bronchoscopy is required in this group of patients if there are new respiratory symptoms and the diagnosis is not obvious. Make sure that samples are sent for the regular investigations, but in particular, cytology to look for PCP, microscopy to look for acid-fast bacilli, virology to look for CMV. Intrapulmonary KS is unusual without cutaneous KS, but not impossible. NB. Sedation in HIV disease. Some newer antiretroviral agents, notably indinavir, efavirenz, nelfinavir, ritonavir, and sequinavir, may greatly slow the metabolism of hypnotic agents by interaction with cytochrome P450. Check what your patient is taking, or he or she may stay sleepy for several hours or longer. CT scan of chest. Useful when other investigations are negative or disease is slow to resolve. Not essential in all patients but can be useful in unexplained hypoxia or fever. You may see lymphadenopathy. Treatment. Pneumocystis pneumonia. High-dose intravenous septrin, oxygen, and steroids, if PAO2 less than 9.3. Do not forget to monitor blood tests carefully, including FBC and liver function. Second-line treatment in those unable to tolerate septrin, cotrimoxazole, is pentamidine or dapsone and trimethoprim. Because of the improved overall prognosis of HIV patients, full supportive care, including intubation and mechanical ventilation, is usually recommended if indicated on physiological grounds. NB. In severe PCP, large cysts may form. Pneumothorax could explain a sudden deterioration. Kaposi sarcoma. KS may improve in patients with a high viral load who are started on antiviral drugs. Otherwise, refer to an oncologist for intravenous chemotherapy. Tuberculosis. The frequency of atypical presentations is increased but management is along conventional lines. Interactions with new generation antivirals are a problem, specialist advice is required. NB. Do not forget that drug regimens are different for atypical mycobacteria and multi-drug resistant TB.